But welcome everybody. My name is Pat Dunn. I'm with the American Heart Association Center for Health Technology and Innovation. And I'm joined here by Carla Robinson from Canary Telehealth. Welcome, Carla. So Carla, why don't we just start out, but why don't you tell us a little bit more about Canary Telehealth?
Sure, absolutely. Thank you, Pat, and the American Heart Association for inviting me here today. Just by way of introduction, I'm CEO and co-founder of Canary Telehealth. We provide telehealth and call center services to help improve access to care and close gaps in care, particularly with an underserved population. Our population areas of focus include chronic conditions and maternal health. Our key services, and a big part of what we're talking about today, so our anchor service is really remote patient monitoring. We also have self-management programs for people with chronic conditions, diabetic retinopathy screenings, and we host a whole series of healthcare outreach campaigns, really helping to get people into care and closing those gaps as I described. Prior to co-founding Canary Telehealth, I spent 16 years in management consulting with McKinsey & Company and the Cambridge Group, where I worked with the world's largest healthcare organizations and health and wellness organizations. And I'm excited about the topic today because my area of specialty in that work was really in understanding consumer demand, both specifically talking to consumers as individuals and then also looking at macro trends and using that as a basis for understanding their motivations and transforming that into strategy and our offering and our communications with them. So excited to bring all of those things together here in this talk, Pat.
Yeah, I'd love to hear more about that. So first of all, let's talk a little bit about the patient and consumer populations that you serve, how they get into your program, but I'm especially interested in how you engage those individuals.
Absolutely. So we do have multiple different populations. So we've worked with Medicare plans, dual, so people are dual eligible, Medicaid managed care organizations. We work with a couple of different types of health and hospital systems, some that would be classified as safety net hospitals and others that are more traditional health and hospital systems, and commercial and retail, frankly. I will say we have deep expertise in underserved populations. So we have a community-based outreach initiative working with people with a hypertension control program through to do a collaboration with community-based organizations. We work with a lot of Medicaid managed care organizations. And frankly, it's a big question that you ask around how do we get and keep people engaged. And there's a variety of different levers, and we could probably have a whole class on that. But I'll tell you some of the key success factors that we found.
Pat, to answer your question, I have my blood pressure cuff right next to me.
Good deal.
Tom Foley, I am the Chief Growth Officer at GenieMD, where we are democratizing healthcare through the use of virtual care services, ultimately creating the home as a valid setting of care.
That's great. So Carla was just telling us a little bit more about the populations she serves, and then she was going to get a little bit more into, how they do it. And she talked a little bit about underserved, under-resourced populations, and then really their strategies and protocols for engaging those individuals. So Carla, go ahead and continue that thought. Oops, and I believe you're on mute now.
Happy to do that. And Tom, I know you wanted some stage setting, so we can, just let me know if you want to jump in.
Mm-hmm. No, if you don't mind, just a couple of words, just to, the title of the webinar is Closing the Gaps in Care with Virtual Engagement Programs. So I just wanted to set the level set. What is virtual engagement? What is virtual care? Mm-hmm. And so we look at it as I always use the statistics from CMS that the average Medicare patient with 5 chronic conditions sees 9 different doctors, and they're in front of their doctors in a given year, a total of 15 hours. The question is, what happens the other 8,745 hours? And that to me is we define as the gap in care. It's what happens at home that's equally and maybe more important than what happens when you're inside the brick and mortar. The point is, are you compliant with your medication? Are you compliant with your overall care plan? Are you dieting and exercising and achieving the goals that the doctor spoke about when you were inside that brick and mortar? So how do you extend that care into the home or wherever that patient might be? And that extension really is through the use of virtual care programs, whether it's telehealth, remote patient monitoring, chronic care management, principal care management, transitions of care management. There's a number of different remote therapeutic monitoring. There's a number of different programs that can be adopted under a fee-for-service model, as well as deployed under a value-based care model that can further engage the patient outside of that brick and mortar to ultimately assist in raising the awareness of the condition that they're in, set the expectations of what their care plan is, and help them achieve that care plan. That's really the critical nature. Help them achieve that care plan. How do we ride the journey of awareness of what you learned about in the doctor's office? You have diabetes, ultimately to a better state of wellness when you're not in front of that doctor. So to me, that's virtual care and the tools. And I'll just add that it's interesting that CMS is stating these objectives of, I'll just read it. The CMS's objective is to ensure all Medicare and vast majority of Medicaid beneficiaries will be in a care relationship with accountability for quality and total cost of care by 2030. That's putting the 1.1 million fee-for-service physicians today into a value-based care model. The question is, how do you leverage what you're doing today? And how do you leverage what you can do under a fee-for-service to help you set the bar as to how you can get the value? So it has the virtual care, and the reason why I wanted to talk about this today from our perspective was, how do we move the needle relative to patient engagement and outcomes, and what's the differentiations in that? Because there's a lot of different things there's a lot of air out there relative to virtual care. And then how do we help these doctors move to value? Because a lot of them don't understand how to get there. And so this is a great opportunity on demonstrating how they can get the value in a fee-for-service program, and then have greater confidence to make that leap, if you will. And I think that that's very important in today's program, in today's discussion, relative to how do we close the gaps in care, leveraging a virtual engagement program. So with that, Carla, I know you're very much involved in this very topic. So from a Canary telehealth perspective, if you can share some of your insights in that regard, that'd be great.
Yeah, absolutely. So as I think about the key benefits that we see in our remote monitoring programs, one of the first and foremost, of course, as you said, is people really learning to manage their condition. So some of the things that people tell us is they now know what their numbers mean. I mean, they know 120 over 80 is good, but if I'm like at 154, do I do something different than when I'm at 147? Right? Like, I mean, it's those kinds of things day to day that people have to sort out. If I have a headache, is it okay to ignore it, or do I take action? And so by having a nurse to turn to with those types of questions, and certainly a nurse who reaches out for triage when their numbers are going out of bounds, it provides them with that opportunity for coaching and feedback, and to ultimately learn through that process how to manage their condition. One of the huge wins we see really is around medication. So shortening that cycle time to getting the medication and the dosing right. So if a patient has medications and they don't like the side effects, or they're troublesome for some other reason, a lot of times they don't call their doctor right back and say that. They just stop taking it, right?
Exactly.
And so the doctor may not find that out for 3 months or 6 months or whenever they see the patient again. And so we find that out right away, because their numbers are going to skyrocket, right? And so we have that opportunity to have a conversation with the patient and to work with them and their provider to get that resolved. The third thing I will see that I would say going into this, I didn't fully think about, but it's what the patients tell us, is that it's strengthened the communication with their provider. So they now understand a bit more of the whats and the whys of the conversation they're having. So they're able to come to that conversation more informed and educated, and therefore able to get more out of what the doctor is telling them. And the provider obviously has better insight into the patient, right? That the other 800 or 8,000 or so hours that you described, right? They now have more insight into what's going on with that patient. So that's the third area, the patient provider communication. And then last, what helps to pay for all of this is more appropriate utilization of services, right? In a value-based world, right, one of the things that helps to pay for this is more appropriate utilization of services. So we're seeing, for example, 40 to 60% reduction in hospitalization cost, right? Because you're just avoiding some of those unnecessary hospitalizations, less ED visits. And importantly, though, more appropriate ED utilization, because sometimes the answer was, you need to get to the ER, right, before something, more serious or awful happens. And we're seeing increased ambulatory visits. So a shift to more ambulatory care versus acute care settings, and to your point earlier, and then most of what's happening is happening right there in the home setting. So those are the key benefits I would say we're seeing in the program that we've seen over the past decade or so that we've been doing this.
Yeah, I think you're bringing out some very key points when we speak to a lot of providers about the adoption of remote patient monitoring and chronic care management, and they have this understanding because of maybe some previous experience or what they've been told by a neighbor or what have you, that remote patient monitoring is just about capturing vitals 16 days out of a 30-day period. Once you do that, you're good, right? So, but that's not true. That is true from a reimbursement criteria perspective, but the value of a virtual care program, whether it's in a fee-for-service or an accountable care model, is really the points that you just called out. Just the fact that we can track their blood pressure, hypothetically, we can then engage, and then the measures are different than what we expect. We can then engage the patient on whether or not they're even on their meds, right? And then we can engage them better on use that ambulatory facility versus that ER. And if you can do that, we can then therefore even 17% of all ER visits translates into an admission, right? But if we can catch a situation earlier, preempt it, and keep them out of that hospital, that ED, and that hospital ultimately, that is ultimately what we're trying to get to, right? We are now taking better care of that patient, and we're engaging that patient more succinctly than just taking a blood pressure measure. The blood pressure measure or whatever physiological measure you want to capture is just the starting point, not the end point in how we change the delivery of care.
So Tom, let's take a quick pause. We have the fourth person on our panel has joined us, Dr. Scott Conard. If you wouldn't, Dr. Conard, if you wouldn't mind just doing a brief introduction, and I think you from both a physician perspective, but also leading a large medical group perspective, and all the work that you're doing really in value-based care. I'd love to get your perspective on some of the points that Tom and Carla were just making.
Yeah, thanks. I appreciate that. So my name's Scott Conard. I'm a family doc and have been involved in cardiometabolic prevention really aggressively for the last 35 years. And so, and Tom, I heard you say it earlier. I actually was listening as a participant where you were talking about the transition from fee-for-service to value-based care. I work with a lot of Converging Health. We work with a lot of medical groups, and it's going from the mentality of, oh, we got to send a CPT and an ICD code in to get paid, to how do we actually decrease the health risk of this human being? And Carla, I
Yes.
think that the Medicaid, and particularly in the United States, is really driving the changes to whole person healthcare, value-based healthcare. It's not enough to just say we check the blood pressure. You really have to reduce the risk and reduce the events and keep them out of heart failure and make sure that you're taking care of the human being. So it's a tremendous time, and you don't have to have people line up like cattle and run through your office anymore, because you're getting paid a full risk capitated amount, and the better you take care of a person, the more you get to keep at the end of the day. So healthcare right now is in this huge transformation where the virtual platforms that Tom, you and Carla talked about, and the populations, Carla, that you've highlighted, the way that we do things is going to become very different. And the solutions and the technology and how we use them are going to become incredibly important as we move forward.
Yeah. Great point, Dr. Conard. Hey, Pat, let's bring the American Heart Association into the equation. All right, we have these programs, and this patient, to Carla's point, this patient is at home. Sometimes, and engagement is critical, but also education is critical, right? It's a matter of understanding, okay, you have diabetes now. What do I do? Right? I'm not in front of my doctor, but my doctor could prescribe, if you will, information, content, programs, on what I should engage, so I can learn how I need to change my behaviors. How do I reduce the risks of diabetes? I always say my father had diabetes, and I've said all along that just because you have diabetes doesn't mean you have to die with it. There are ways to put that in remission. You just have to be willing to do it. So tell us a little bit about what the American Heart Association is doing relative to content and programs that help facilitate greater quality of a virtual care program.
Yeah. So thanks, Tom. So obviously, we're very interested in programs like what Carla runs. Especially from a hypertension standpoint. Blood pressure is one of the most important risk factors, not only for preventing heart attacks and strokes, but really for overall health and well-being. We know that the traditional way of getting most of your information from your doctor in the doctor's office in that 5 to 7 minute time period, it's great for setting a plan. It's not really conducive to really all of the information that an individual needs. So, we really see these virtual programs, number one, as a way to deliver that additional information that they need to be more successful in managing their care. And number two, it can extend to a larger group of people, people who don't necessarily have great access to medical care. Maybe they have to drive, 50 miles even to get to the doctor's office. It's not going to happen very often. So we can use these tools to provide better access, but also a richer, deeper experience in helping these people lead, longer, healthier lives.
It strikes me, Pat, that with the American Heart Association and the health literacy efforts that I know you've actually written books on health literacy. And so one of the things in this shift that we talked about, Tom and Carla, is the mentality going from fee-for-service to value-based, is the patient's role changes. In the fee-for-service world, all I need you to do is be a corpse, or not a corpse, but a living person that I can check a blood pressure on and send a code off, and I get paid. Now I've got to actually have you be healthy. And that changes the emphasis on the importance of health literacy. And that's where I agree with you, Tom. I think the American Heart Association, with their focus on improving the health literacy and the access of care, which, again, the second point I was going to make was that that it doesn't matter where the care takes place anymore. So being able to take care of that person who lives in the country, Pat, and on site saves money for the office. It saves administrative time, and it improves outcomes, which ultimately is what you're getting paid for now.
And we still know that it's hard. And that's where programs like Carla's come in that really help engage people. And there is a lot of healthy skepticism among patients and healthcare professionals about the utility of these tools. But I know in your case, Carla, you've got some great examples. So how does your system actually work, and how do you actually engage your customers, leading to better health?
Yeah, great. So um, we have a program that provides a care plan based on the evidence-based content from the American Heart Association. One of the things we find really important for people is figuring out how they can implement the changes in their own lives. So as you said, Pat, the plan that they have, the treatment regimen that they have when they leave the doctor's office, but how do I implement it? What does that look like? And what are the specific changes in their diet, the meal ideas and the recipes, the ingredients that they can swap out? So we have a lot of options available to them, a lot of questioning and assessments, right? So we listen as much as we talk, to find out, like, what are they looking for? What do they struggle with? What are they motivated to change? Of all the things they could work on, what are the things they want to work on? And then we're able to provide them with tools and supports in that. One of the things that I think is important, we all know intuitively that not everyone approaches healthcare the same way or has the same motivations, but often the programs that we design don't take that fact into account. And so as you think about, the world I came from, where you segment people based on their behaviors and their motivations, and you use that information to inform what you offer them and how you communicate with them and message them. And so I bring that to this world where our team is listening to folks and figuring out what are their specific motivators, and then how do I, not only what do I serve them up, but how do I serve it up in a way that resonates and aligns with those. I think another key point really is that it needs to be relatable and feel accessible. So in the imagery, we want imagery that looks like them. We want them, as we talk about recipe and diet ideas, that it's culturally sensitive. That we consider, when we're talking about exercise recommendations, that we consider the range of living environments that people are in, and how can they take action on the things. And so it's not necessarily run a mile, right? It's some of the Heart Association recommendations around 10 minutes of walking, right? And the like. And then I think the last one is, it's about relationship. So I think across all sorts of settings, you can imagine people are more prone to stay in relationships when their needs are met. And so particularly when we're serving an underserved population, but it goes across the board, but we run into lots of needs. And we have our team is very well trained to be empathetic, to do perspective taking, and we have processes and procedures in place when we hear things, how to get help. So we call someone, ask them about being on the program or their adherence with the program, and if they tell us stories of grief or loss or struggling with stress or anxiety, or infestation in their home, even all sorts of things that some things that have totally, are quote unquote not directly related to what we're serving. And if we say, wow, that's too bad. So about you taking that reading, it's not going to go very far. So it's really about building relationships. So many of the things that we know just about what we want and need from folks and products and services that we interact with, we bring that right to bear in this space. And if I can just share one example. So there's a patient who started out with an A1C of 12%. So he didn't know he had diabetes. He went in to see his provider and he had an A1C of 12%. Family history, and the provider said, we're going to put you on insulin. And he said, no, I don't want that. I've seen the way that looks and I want to avoid it. And she's like, all right, you get one shot at this. He went away, and thankfully he's got a wife who was like, all right, we're going to jump on this. But he got a dietitian and all sorts of other things, wonderful aspects of that story. But I'll share this example with you from the provider standpoint of the dietitian. The dietitian could have told him, stop drinking alcohol as one of the things in his diet. It wasn't going to land, right? I mean, and so that wouldn't have been, information was going to accept. He wasn't going to engage or what have you. The provider said, switch from tequila to cognac because it's lower in sugar. Have a shot with a chaser of a zero sugar beverage, and then drink a ton of water afterwards. Things like that. So that's one example in the dietary changes. This patient has dropped his A1C from 12% to 5.8% in a 6-month time frame.
God bless them.
But it really starts with, so all the credit goes to the patient, right? For the discipline, and his wife, for the discipline.
Probably the wife more than the patient.
And right, we've got to have a team that is engaging people, meeting them where they are, and giving them accessible behavior changes to implement.
Carla, that's a great story, and reality of what's happening in the home. I think what you're calling out is a lot of how social determinants of health and your surroundings, including your family, is, in my view, part of that social determinants. How that all influences whether or not that patient is going to be motivated to engage in the program that's been prescribed in that brick and mortar facility when they're at home. What are your thoughts on that?
Absolutely. So there's one quick example. We had someone whose blood pressure was, just kind of always spiking. And we called her, and she ultimately said, look, my daughter has some struggles. She's not, and I have her children. I'm, 70 years old, and I have 3 small children. My blood pressure is going to be high. So if you just keep calling me every time my blood pressure is high, this isn't going to go very well. So let's talk about some ways to get some supports with her, and let's talk about other things that she can do to mitigate and manage her health. How does she relieve that stress and what have you? But we have to be unconventional and frankly, taking into account social determinants of health. I no longer consider it unconventional.
Yeah.
I consider it it's part of what we have to do to get the results we and they want.
Interesting.
Well, again,
Doctor, I was just going to come to Carla. Talks a lot and brings a lot of rich insights as to the patient side of the equation. You speak a lot with the payers and the providers and the ACOs. What are they striving to do in the context of how do they change their delivery of care models by leveraging virtual care programs?
Well, I think that's where they are right now, to be honest, is realizing it can't be a transaction, as Carla was pointing out. The old fee-for-service world of a transaction is going to have to go away because you don't actually improve people's health often by just sending in CPT and ICD-10 codes. As you shift and you start to ask the question, what's the relationship look like that actually has to have this person be effectively managed and decrease the events of strokes, heart attacks, kidney failures, and all the other cardiometabolic problems we see, then the importance of the health literacy, the importance of the relationship, the importance of being able to take care of them in place. I know the American Heart Association, Pat's done a lot of great research on the importance of being able to take blood pressures in the community and coach people in their community and see them and meet them at their home. It really is where we are right now as a healthcare system in evolving to that value-based care system. And it's very challenging. I mean, COVID really did a lot for telemedicine. And we proved that with telemedicine and video medicine, we can take excellent care of people. We're tending to slip back into the old ways now instead of leaning forward, where virtual in-place care that's based on relationships, that's easy and convenient for the patient, high patient satisfaction, low hassle, is being utilized to the degree it can and should. So I think you two are probably 2 years from now, the healthcare system will revolve around companies like yours. Today, people are still trying to figure out how do they fit in. And I think the American Heart Association, with its leadership and vision of the importance of moving from transactions to relationships, from going from do this, do that, to understanding that person's why, which Carla, in the story you told, the reason that she's now, really going to want to take care of her blood pressure is because she's got 3 kids that she's going to have to stay alive for and really take care of. And so she's got a very powerful why, and she'll do things differently. The gentleman you talked about, I used to have truck drivers that would come in and they get to the point where they had to go on insulin, which meant they couldn't be a truck driver anymore. And man, the second they were told you got to go on insulin, they were ready to lose 50, 70 pounds and not have to go on insulin. So understanding that person's why, they're having the relationship with them to leverage off of what's going on in their life and then bring them really competent information like the AHA offers is really three of the key things, I think.
Dr. Conard, do you think that there's a misalignment in the understanding of, maybe not the understanding of value-based care and what it could do, but a misalignment in the pace in which we need to get there? And so let me, so for a payer to step in, what they're ultimately doing is they're stepping between the provider and the patient relationship because they want to deliver this care. And the provider is saying, hey, I want to deliver this care directly. It seems to be, so that ultimately says to me that there's a misalignment in how we get there. And I think that's actually the bigger problem. And I don't want to get into it in this discussion, but when you have, 5,000 plus hospitals and then 1.1 million different providers out there, there's no leadership in how do we get to where we're going, because everybody wants to do it differently and everybody's got a different set of noise amplifiers out there. And those physicians just don't have the right guidance to do what they want to do in their practice.
Well, again, as we do, yeah, go ahead, Pat. No. Yeah. So, so what you're pointing to, Tom, is that everybody needs to work at the top of their license and nobody needs to do something that other people can do just as well. And with the management of hypertension as an example, a social worker, a dietitian, a pharmacologist, an exercise physiologist, and then the MSW, which can be helping them find social services, or it can be actually coaching them. Those people actually are more effective at treating the individuals in their home environment probably than a physician will ever be. So in this new value-based move, what you're going to see is a lot of the tasks that physicians are being expected to do today are going to be offloaded. And companies that have the ability to bring other resources, that less expensive resources usually than the clinician, to bear to raise health literacy, to empower people, educate people, and have them do things a different way. Because again, it's you want to get a different outcome, but to get a different outcome, you've got to have a different behavior. But to get a different behavior, you've got to understand the person, the human being. And it's more than just saying, check your blood pressure, come back in so I can send a 99213 out again. And that's where right now healthcare is trying to figure it out. And that's where the more comprehensive whole person, social determinant included view that you were talking about, Carla, I think is the shift that we're going to be moving to in order to be effective in value-based care.
Another shift, which I think could be a benefit to the healthcare system with the use of technology and with things like artificial intelligence, is taking a lot of the administrative burden away from the healthcare professional and let them really do what they're trained to do, which is take care of people. You mentioned ICD-9 or 10 codes and CPT codes. All of that is doing, the administrative functions, all of the documentation. We hear doctors talk about pajama time. They go home, they put their family to sleep, and then they, spend several hours just finishing their documentation for the day. And, frankly, for somebody who's gone to school for 20 years, that's probably not the best use of their time.
Yeah, no, there's no question that again, all that administrative stuff needs to go away to the degree we can possibly do that for the clinicians. And so, Carla, when you think about this and you think about the team approach to care, because that's where we're going, it's to a team approach to care, and Canary Telehealth, how do you do that? How do you accomplish that? What are you looking at in terms of bringing a bigger set of resources to that individual?
Yeah, great. So one of the things, obviously people with chronic conditions vary widely in terms of their severity or extent to which the condition is in control. And And so we align the resources appropriate to, we'll say the risk level, right? And so there are some patients for whom the high touch of a nurse and a clinical team makes a whole lot of sense, and it's really necessary. There are other teams, patients who a lot of those other practitioners that you described are much more front and center. So maybe it's someone helping them figure out an exercise routine or figuring out their diets. So as we kind of start with, we've got some good hard numbers to start with, right? A good starting point on how many hospitalizations or ED visits they had, and the like, to give us an idea. But then once we get them, we have a better sense for which program they most align with. But our nurses and medical assistants and dietitians work wonderfully together because we're able to share that information in the platform, escalate when needed. Very often it's the medical assistant who's talking to them just about they've got some technical support issue or what have you, and then find out all sorts of other things that need to be addressed, and we're able to escalate that. One of the things that I think is really important, I alluded to it earlier, but you want to have a really good protocol in place for those handoffs. Because there are folks, even our non-clinical team members who are on the phone in the call centers, get a lot of really rich information, a lot of good insight that not well trained could just go over their heads. And so you've got to have a good listening ear for, that's a window of opportunity. Either something that needs to be addressed, a need that can be supported, or it gives insight back into that why that we've been talking about, that then can be used by the nurse.
So we do have a question from the audience, and it's related to what we're just talking about. So the question is, all of this talk of knowing the patient and the human being patient and person-centered care, all that sounds great, but is it scalable? Can we really reach all the people that we need to reach? So why don't we let Carla address that first, and then I'd love to hear Scott's reaction to that as well.
That's exactly, Pat, what took us down the path of the self-management program, because not everybody needs a nurse looking at their readings and responding, but they need this information education that we've been talking about. So one of the things we were able to do in the GenieMD platform is, as people take their readings and they're getting questions about the readings and automated feedback on that. And so we've got the feedback in there that's based on American Heart Association guidelines. But what also we're able to do is our team looking at that can discern patterns and trends and send them information that's relevant to what has been happening. And we can do that in a bulk fashion, right? We're able to pull reports and figure out, here's a bunch of folks here, here's a group of people that on these types of questions around, let's say I've been picking on diet and exercise a lot, let's pick on smoking now, right? That on these smoking questions, whenever you ask them on a weekend, how's your smoking going? You get a different answer, right? And so there's education that we can provide in bulk to that group of, to folks on that very specific observation around taking off on the weekends doesn't, it doesn't really help you. So, and so that's how we think about it. There's lots of reporting and analytics, AI that we're able to deploy, but that gives us insights into subgroups within the population, and then we serve them up with relevant material to support them.
So, Dr. Conard, we also know that there's shortages of nurses, of physicians, especially in some of these rural areas. So how realistic is this, as far as really making this scalable on a big scale?
Yeah, it's interesting to me because the fee-for-service system has proven that it's incompetent and unable to manage hypertension beyond a reasonable doubt. There's no way. I mean, a stroke and a heart attack is a medical failure. A retinal, kidney failure, blindness, Those are medical failures. So the current system doesn't work. It makes a lot of money for a lot of people, which I understand, but it's not able to work well. So then let's say we flip that on its head and we say we're going to remote monitor the people who are at high risk of having hypertension or have a known history of hypertension, and we're going to set up a system where we're monitoring them with inexpensive technology and more less expensive people, in the sense that maybe it's the medical assistant Carla talked about, maybe it's somebody who's just a trained technician who's able to monitor the results that are coming from this kind of IT monitored system in their home, watching what they're doing. And then when things go wrong, we reach out, we talk to that person, we figure out what's going on. Is it real? Is it not? Was it just an artifact, or are they really having a significant problem? And we treat them just in time. So the point of the remote monitoring and the point of this technology is to decrease the cost, to make it more scalable, and to actually do something when we need to be doing things, instead of saying, come back in 3 months and let me check your blood pressure, or come in a month, which is an artificial blood pressure. It's not accurate. There's white coat hypertension. There's cuffs that don't fit properly. There's people who didn't walk in, sit down with their low back supported, taking deep breaths with their, the cuff at the level of their heart, with their arm relaxed. So we're getting garbage readings in an artificial environment, trying to treat based on that, and we fail, and they stroke out and they have a heart attack, or they go into congestive heart failure. And so this is the hope of the future, that using the technology, that leveraging is a much more scalable, effective platform, because what we're doing now isn't going to work. And I agree with the individual who asked the question, though. Is it realistic for a physician, I'm a family doc, to really have this deep relationship? And the answer to the question is, it's probably the MA, which Carla mentioned earlier, that has that rapport, that spends a lot more time just talking and understanding that person. And that's where team-based care's got to come in, and communication's got to start to occurring. And we work with a large group of 180,000 Medicaid patients in Queens, New York right now. And and what you see in that population is people who are neglected. They're not treated well. They're not treated with respect. They're kind of the outcasts of the healthcare system. But when you put a team around them, and you have people who often are their neighbors working as MAs or receptionists in the clinic and the center, we call it, is the term they prefer, all of a sudden you get a different level of insight. And inside the medical record, they use Epic. They have what they call the storyboard, where all of the different members of the team are sharing the story that they're learning about this human being, not this transaction, this human being. And pretty soon you're making much more responsible, competent decisions that are going to decrease events and save money. And now all of a sudden the CFO can't get enough of it. Whereas before, the CFO is just like, let's do a procedure. Let's do a procedure. Come on, let's go.
And can I ask,
So if I could add just one point there, scalability is has multiple sides to it. From a resource perspective, just because you're treating the rural area doesn't mean your care managers have to be in the rural area, right? So you want to leverage the larger population and their geography to benefit the value of reaching into that rural area to provide that delivery of care. That's one aspect of it. The other aspect of it is you want to make sure that your entire program, your platform, is scalable in many different ways. Scalable in that it can serve multiple clinical categories. Right? It's not just for hypertension. It can serve multiple categories. As well, it can provide a diversity of programs. It's not just about remote patient monitoring. It's not just about chronic care management. It's not just about telehealth. You don't want your providers out there to need to mash these things together and think that because they're not IT people. But so your platform can be modular and scalable in context of functionality and programs, and your reach in context of clinical categories is another, and then certainly your people, the people that are touching the patients, as well as your technology that touches the patient, provides this whole unique experience at the end of the day.
So I know we got a little bit of a late start, but I know a lot of us live by the clock. So as we wrap this up, we do have one more question, but I'd like if everybody could go around the horn, I'll ask the question, but also if you had any just final concluding thoughts. So the question is, how do we measure success? What do metrics look like, and what should we be looking for? So Carla, if you wouldn't mind starting, maybe start with the question, but also some final thoughts from you.
Yep, great. So, you obviously have to be looking at the data from an individual patient level as well as at the population level. And we look at both intermediate, right, and ultimate outcomes. So when we see changes in knowledge and from literacy, we consider that a win. And then we move to changes in behavior, we consider that a win. And then ultimately, we're obviously measuring the change in biometric outcomes. And then you have to consider different sources of data. So often, my background, I go straight to the numbers, but you also got to listen to some of those anecdotes are really, really powerful, and they help you imagine what the patient experience and journey is like. And wow, if there's one person like this, there's probably a million, right? And then we help to figure out, and that informs us. But then at the end of the day, who are we all doing this for? It's for the patient. And so a key way that we measure success here, I don't think of it just in terms of customer satisfaction. We want to do some good hygiene around that. But what has changed for them in their reality? And so we field a survey with the patients around, what is this experience doing for you? How has your life changed in this past year as a result of this program? And those are the things we want to hear about. And ultimately, their health outcomes and their life experiences is what we look to inform success.
Thank you. Dr. Conard?
Okay, or Tom, I'll defer to you. Go ahead and go next.
How do we measure success? At the end of the day, it's all about outcomes. Whether you're in a fee-for-service model, I personally believe virtual care can change fee-for-service. That's just my own passion, as I've alluded to in the beginning of this conversation. But at the end of the day, it's all about how do we facilitate that patient's journey from awareness to wellness. I just became aware I'm a diabetic. I need to be I need to be engaged. I need to be educated. I need to change my behaviors, and I need to work towards wellness. And wellness is ultimately the outcome that all the payers are looking for, because without it, they'll do nothing, frankly. And that wasn't meant to be derogatory, but at the end of the day is, how do we improve patient outcomes at a much reduced price point than what we're doing today? And I think if we can drive, and I think that the measures of when you're looking to engage a virtual care platform, you need to look at how are they compliant with current criteria, and how that's on the fee-for-service side, and how have they produced a change in and outcomes and performance that you typically would measure in a value-based care model. I would argue that if you're looking for a virtual care program, don't look at it from a fee-for-service perspective. Even though you're in a fee-for-service model, look at it as to how you can drive outcomes as if you were in a value-based care model.
And
Yeah,
Dr.
and Pat,
Conard, close us out. What is
all right, so and Pat, I'd answer the question, depends on who I'm talking to, right? In the sense that if you're talking to the patient, which is what Carla said, it's how's your life? How has it improved? What's working better for you? And we know that empowering, raising health literacy, having team-based care, having resources available, and being able to take care to them all make a huge difference. If it's the clinicians, it's the MAs, it's the receptionists, it's the nurse practitioners, the physicians. It's how easy is it for you to live out your life's mission, which usually is to improve the health of people they serve. And what you see is when you integrate this technology in a team-based platform, it actually does wonderful things to the happiness of the team. If it's a CFO in a fee-for-service, in a value-based world, it's here's how much money you're not spending because people aren't having heart attack, stroke, kidney failure, blindness, and this is why that's happening. So you have to kind of tailor the message to the audience, but what we're talking about today is the future of healthcare. It's the future of health and well-being, and technology, AI, large language models, team-based care, being able to use remote monitoring, it's all a part of that patchwork that's going to have us be successful.
Great. Well, with that, thank you all for participating. Thank you for hanging in there with the technology as we got started, but I think we had some great conversations. So have a great day, everybody.
Thank you, Dr. Dunn, for your leadership. Appreciate that.
Thank
Yep.
you.
Thank
Yep.
you.